Colleagues, we are starting our first session, which is focused on end-stage congenital heart disease, the high or moderate risk groups, prognostication, that I'm co-chairing with David Celermajer, who is up on the mountain peaks of the South Wales in Australia, and he'll be joining us shortly. There is a bit of a change in the program in that sense. I would suggest that we take questions after each presenter. And the first presenter on the program is Craig Broberg from Portland. And Craig is with us. And I'm delighted to introduce briefly Craig, who is an authority in ACHD with an amazing path. Spent some time with us a couple of years, about 15 years ago at the Brompton, went back to Portland, the West Coast, and has done really groundwork there, both in Oregon, but also in North America. Craig, delighted that you're with us and your talk on the systemic right ventricle, which is still concerning. Thank you, Craig.
Thank you, Michael. Appreciate the chance to be here. Good morning, everyone, or good evening, depending on where you are. I'm in Portland, Oregon, as Michael said, and for those of you who've been able to visit, I hope you'll think of it as a pleasant city, despite the fact that our skyline has changed a little bit recently. With civic unrest and ash in the sky, the world has changed for us in Portland too. And all this just reminds me of how important our global community is. I want to thank Michael for reinventing this meeting virtually and allowing it to continue so that we can have this collaboration, as the Baroness just reminded us, and move forward. I'm very pleased to have the chance to participate. There's been a lot written about the systemic right ventricle in transposition mostly. This contemporary review from Margarita and Gerhard and Michael in the last 2 years has a lot of the details that I think I'll refer you to, especially since I don't have time to get into too much in this short period. Among that which is written is things that give us the understanding that there's quite a spectrum of ventricular function in this group, from very preserved systemic RV function to severely reduced systolic function. In these two images I'm showing you here, the first on the left is a woman who's 75 years old with very normal function, whereas the patient on the right is 25 years old. So great differences in how these ventricles seem to fare. There's also an understanding of a spectrum of clinical manifestations. All of these three individuals, men with an atrial switch palliation in the past, have similar metrics of their systolic performance, but very different clinical manifestations. On the left, this patient is completely asymptomatic, works full-time as a mechanic. The patient in the middle has had early arrhythmias and some heart failure manifestation, otherwise doing well. The patient at the right was transplanted about 6 months after this image. So clearly there's lots of heterogeneity that we have yet to understand in terms of how the ventricle fares and how the patient does with the ventricle that they have. So for my talk this morning, I will speak to these two versions of systemic right ventricle in the setting of transposition. I will use these two acronyms and their colors uniformly through the talk. I will speak to prognostication and various management questions of the end-stage right ventricle as instructed. And I'll draw upon published studies as well as some multicenter data that's just emerging. And I will introduce the multicenter data very briefly here by saying we've conducted, on behalf of the ARC network in North America with funding from the American Heart Association and the Children's Heart Foundation, a large international retrospective cohort study trying to add a couple zeros to the denominator of some of our studies in this field. This is a study that included all adult patients with a systemic right ventricle in the setting of transposition that are seen in ACHD clinics at least twice a year apart. So this is designed to try to get rid of patients who were either late referrals or lost to follow-up. And we simply collected all existing medical record data relevant to our topics at hand. This truly has been a multi-center collaboration. My slides will advance. Where's the next slide? There we go. We've reached out to colleagues all over the world that have helped contribute to this. I want to share the podium virtually today with Alexander Van Dissel, a fellow at in Amsterdam with Barbara Mulder, who spent some time with us in Portland and has done a lot of work with me on this particular topic. She and I have been looking through all the data and the numbers a lot this summer in preparation for this talk, as well as other things, and trying to tell the full story of the systemic right ventricle. Our study has now gathered over 1,700 individuals, 1,100 or so with detransposition and about 500 with CCTGA. You'll see the more complicated anatomy as expected in the CCTGA group. The study suffers from inherent limitations, survivorship bias among them, and referral bias. I just want to mention those up front. It's retrospective, so not all patients had all data elements. And there's inherent heterogeneity between centers about how patients are managed that all need to come to be understood in the study. Now, we've got a cohort of DTGA patients with a median age of about 28 at their baseline visit, a little bit older for the CCTGA patients as expected, with follow-up for either group of about approaching 10 years. Now, so back to the questions at hand. Who does well and why with the systemic right ventricle? What is their prognosis? Well, the first study to address this, I think, in a systematic way was from Scandinavia, where they identified 468 individuals born with DTGA and accounted for all of them with their excellent general population data. They showed 60% survival over a 30-year period. Now, keep in mind that a lot of that mortality is up front in the neonatal period before surgery. So with different surgical areas or techniques, one might expect the curve to look a little differently and have implications for the 30-year survival. That said, the only risk factor they could identify as a long-term predictor for outcome was the presence of a pacemaker. So it begs the question, what happens to this population at the 30-year mark? You know, are they on a continual decline, or are they going to drag out their survivability? And that's where many of the questions still lie. Our colleagues in New York recently did a meta-analysis of all the published data on this and scrounged together about 5,000 patients from the literature and showed 65% survival over 40 years. So dragging things out a little bit here, I'm cheating statistics. These Kaplan-Meier curves are not superimposable, but it gives us a sense that yes, even not accounting fully for survivorship bias, maybe the survivorship here is better than we might expect. Risk factors that they found in their study included SVT and complex anatomy. So in our multicenter data of 1,700 or so patients, we're finding 60% survival at 65 years. So again, in essence, dragging this out maybe a little bit further. Here's what the real Kaplan-Meier curve looks like for our study. The DTGA patients do a little bit better than the LTGA patients. Keep in mind that they are younger than the LTGA patients. But the majority of patients are still alive as the study unfolds. You know, keep in mind also that this time zero is a baseline visit when they're first seen in the ACHD clinic. So not representative of the full cohort of patients born with this condition. But it is representative of the type of patients we see in the ACHD clinics throughout the world. What factors were associated with death and VAD and transplant, which we merged together? Well, for DTGA, it was age, associated complex lesions, RV function, peak VO2, atrial arrhythmia, VT and or the presence of an ICD, sodium, diuretics, and BNP, all measures of heart failure, and the presence of a pacemaker. For LTG, keep in mind that these highlighted ones are consistent with the two studies that I've just shown you. For LTGA, similar findings with the addition of LV systolic function, the subpulmonic ventricle, tricuspid valve function, importantly, creatinine and hypertension and diabetes. Keep in mind that, again, this is an older cohort. Generally, 79% of patients die of heart failure or heart failure-related issues, such as arrhythmia or sudden cardiac death. When you read the narratives that were given about how these patients died, you see that sometimes it's they're very blurred distinction between sudden cardiac death and heart failure because they so often coexist. 67 had been admitted for heart failure, half had had a previous atrial arrhythmia, a quarter had a previous ventricular arrhythmia. And interestingly, there were 4 deaths from cirrhosis and/or hepatocellular carcinoma. So let's get to some end-stage management questions. And I think among many questions, the ones that come up most commonly are, should my patient be on heart failure medications? Should the patient have an implantable cardioverter defibrillator? And when should I consider advanced heart failure therapies? These are the things that patients come to me asking, and I need to give them answers. So let's see what we can come up with to try to address these with our current literature. There are other questions which I don't have time to discuss at this talk. So meds. We already know that there are a lot of relatively small studies out there, some done very well, but the results of which haven't shown convincingly a role of medical therapy. This figure comes from a table done in a sponsored objective review as part of the guideline writing committee a couple of years ago in the United States. And Elisa and Ali and Ariane Morelli, who did this work, found no pooled benefit of beta blockers or ACE inhibitors, ARBs, for the objective endpoints that they were able to study. Now, still, this is a small number of patients with limited follow-up, to be sure, so limitations, but no convincing evidence that these medicines are favorable. In our own multicenter data, a lot of patients are on these medicines with either D or L transposition, a quarter on beta blockers, almost half on an ACE inhibitor or an ARB, and about a sixth on a diuretic. And we found worse survival in those on the medications. Now, you'll immediately say to me, well, this is a retrospective study, so you can't conclude much, and that is very true. It most certainly is that the patients who were doing worse were more likely to be put on these medications. We've looked at this. Patients who were on beta blockers at the baseline visit were older, more likely to have had AFib or flutter, more likely to have had a heart failure admission or have a pacemaker. For the ACE and ARBs, they were just a little older, otherwise not so different. So we've got a lot of work to do in propensity matching, if we can, to try to tease this out better. But keep in mind that we found worse survival, not just equivocal survival. If you look at the hazard ratios here, they're not very suggestive of a role for these medications. Now, I'm not going to claim that they are actually harming the patients by any stretch. Our data does not show that, but it gives us a sense of the amount of work it will take to try and show any benefit at all. Perhaps the one as most favorable is the CCTGA use of ACE inhibitors and ARBs. Maybe we can work out something there statistically. We'll have to see. But the bottom line is that despite plausible roles of medical therapy in the systemic right ventricle, borrowing from other heart failure literature, and this demonstration of the presence of myocardial fibrosis and its impact, something that I have studied and talked about and believe in, and glimpses of favorable responses in some randomized studies, it seems it's going to be hard to demonstrate favorable responses to these medications unless we have studies with literally thousands of people. Moving on. Should I offer the patient an ICD? Well, the published data includes this meta-analysis from the New Yorkers again that showed 45% of all deaths were sudden cardiac deaths. So certainly we understand that there's a role of VT and VF in this patient population. The risk factors for sudden cardiac death that these authors found in their pooled data was SVT and complexity anatomically. Now, in some other studies I'm going to just briefly highlight. This one showed no shocks in primary prevention groups. If you had a device after a VT, VF event, okay, sure, those were more likely to be used, but the ones who had it for primary prevention, not at all. This goes in at odds with another study that showed no shocks in a secondary prevention group, not primary. Another shock study, Paul Carey's going back a few years ago, showed fewer shocks in the primary prevention group. So we've got some mixed bags here. Pooling published experience includes these columns that show that the annual rate of appropriate discharges in patients with a systemic right ventricle and an ICD is lower than the annual rate of inappropriate discharges. We know that many people get their device used for intraatrial reentrant tachycardias. And lead complications are not trivial either. So those are maybe the negative aspects of having the device in place. Well, what did we find in our own data? Well, risk factors for VT or VF for either anatomic subgroup included age, RV function and size, tricuspid valve regurgitation, creatinine, QRS duration, and a previous heart failure hospitalization. So it's a heart failure story largely. These are metrics that are consistent with guidelines from the PACES HRS authors that give a class 2B recommendation for some of these things in bold. The things that were not predictive were need for other surgeries, atrial arrhythmia, pacemaker implantation prior, syncope, prior EP study, or beta blocker use. It's things that I think I was surprised by. We had 152 patients with defibrillators and detransposition. Another 100 with congenitally corrected transposition had a defibrillator. Almost all of those were put in, over half were put in for secondary prevention indications, according to the contributors. And the shocks were on the order of about 2% per year for either group in secondary prevention. What about those who got it for primary prevention that had not yet previously had an event? Well, that was a little higher for the DTGA group, about 4% per year. And so it begs the question, who is getting shocked? These devices are being used. So when we looked at patients with primary prevention ICDs and asked what predicts ventricular arrhythmia events in them, is it age? Is it beta blocker use? Is any of these things listed? Well, none of them were predictive. So again, we're challenged to understand who's really going to go on to need these devices and in whom is it worth running the risk of inappropriate shocks or lead dysfunction, etc. In my mind, I keep coming back to this important study that Ricky Reidman and Sonia Babu-Narayan conducted at the Brompton, among others. And they showed this important role of atrial tachycardia and fibrillation as sort of a harbinger of other events to come. And that, I think, holds true with the clinical practice that I see. However, in our we did not find that to be the case so far in our analysis of our own data. So more work to do. My third and last question, when should I refer for advanced heart failure therapy? I'll just briefly mention some things from the INTERMAC study. It included 45 patients with a systemic RV, among others, and they were more likely to have some end organ dysfunction after implant. Other case reports out there amount to about 30 cases. One of was a death. There's probably some publication bias reflected there. In our multicenter data, we can account for 17 implants, which was a small fraction of the overall population, mixed both D and L transposition. Only one with complex anatomy. So we're probably choosing the ones that we think are more favorable for these. After 2.5 years or so, there were 6 deaths, so 35% of those who got a VAD. And some of those were from cerebral hemorrhaging or thromboses. 5 were transplanted. Of the patients in our group who were either listed for transplant, 54, 16 never got an organ, and 31% died after about 3 years, so a high-risk group. 37 were successfully transplanted, about half and half of each anatomic subtype. And, there was 1 death 3 months after being in the hospital. Otherwise, they seemed to do okay, consistent with larger studies showing transplant successes in our ACHD population. So I would conclude then for advanced heart failure therapy that the general picture of outcome is worsening heart failure. VADs are utilized in minority and sometimes with poor outcome. And transplant seems to be the best option for these patients, which is what our heart failure transplant folks keep telling me, and the literature I think would bear that out. So let me wrap this up here. I've said a lot rather quickly. I think many patients with a systemic right ventricle are doing better than perhaps expected. The outcome is largely reflective of gradual progressive heart failure and all of the things that go along with it, including arrhythmias. As yet, there is no clear role for heart failure medications. We'll have to see if over time we can work out better ways to prove or disprove their use. And ICDs play a role in both primary and secondary prevention, so we should not ignore them, but we have to recognize their limitations. And the best management is probably getting them a heart transplant before it's too late and they die of other organ dysfunction. Thank you very much.
Thank you, Craig. This is a splendid talk and compliments for this global operation with clinically relevant data and a great start to our meeting. I think David Celermajer is with us now, my co-chair. Hi, David. Good to see you. I think colleagues, our delegates, are working their way towards submitting questions in writing, as what you've said at the very beginning. But maybe I have a brief question for you, Craig. We have a few minutes for discussion. After this major step that you've taken with colleagues, what do you think is the next step? How do you see us moving forward and sort of a prospective effort? Do you have priorities in mind? Discuss this with us briefly, please, Craig.
Sure. Well, first of all, we've got to finish our math on our end. Everything that I've shown you has yet to be published and therefore scrutinized through the process of peer review. And that's going to be an important step. We also have a number of, I think, sub-studies where we want to drill in a little bit more and answer some of these questions. Look at the arrhythmias in more detail with some adjudication. Those types of things would help. But by and large, this study was designed as a way of doing some hypothesis generation to then plan more robust prospective studies that I think will give us more clear answers than this type of study design can do. So that's where we hope to go eventually with this data.
Thank you, Craig. David. Craig,
it's David. I was wondering if I could ask you a question. That's a huge amount of work, so thank you so much for sharing that with us. A 40-year-old patient comes to see you in your routine clinic who's a post-op mustard, who's doing well, they're not in heart failure clinically, moderately impaired RV, had one episode of atrial flutter from which they've been successfully cardioverted. So like a really typical mustard who comes to clinic and they say, you know, how long have I got and what's going to happen in the future? On the basis of everything you've done so far, how do you prognosticate for that kind of average patient?
I tell them up front, it's a great question. I tell them up front that how hard it is. Now, let me just take a minute to share one little slide if I can, if this is still, if I'm still able to do that. Let's see. Tell me, Michael and Dave, you can see this slide, but this is,
yep.
This is, these are people in pink who had a major event. They died, say, or got a transplant. And the ones in green did not. And this is the last, this 0 is the last time we saw them or know about them. And you can see that a lot of times people are having things right up front, right? But look at the time span of when these events occur. So David, in the example you just asked about, atrial arrhythmia. You know, sometimes that's occurring 40 years before they have something major happen to them, 20 years, 30 years. And so when the patient comes to see me in clinic, I have a hard time telling them what's going to happen to them in the next 1 year or even 2 years. Maybe I'll say to them, you know, in a 5-10 10, 20-year span, you're very likely to have another atrial arrhythmia or have some of these other things happen to you. But short of that, I really don't know. So I'm usually fairly honest with them in saying all the things that we don't know. I try to educate them as best I can about the shortcomings of our knowledge. And I say, hey, live every year as, enjoy it to the full and take advantage of it. But there's so much heterogeneity in this population that it's hard to drill down.
We add to this, our mantra has been, and you'll see this discussed again and again, the patients should try to be slim and athletic. And we have a session tomorrow morning on exercise and its impact, a general impact. So that great talk, Greg, and we need to move on. I really appreciate you staying up late to be with us. And